Right, welcome everyone. Good morning. Thank you for being here. We're just going to give it 2 minutes to let folks log on, and then I'll go ahead and get us started. All right, good afternoon, everyone. Thank you so much for joining us today. The Region 9 team is really excited for you all to be here. I know it is lunchtime, so please feel free to eat, do what you need during this time, and we really appreciate you spending an hour of your day with us. Today, we are going to be joined by Brandie Bentley for the Advancing Inclusive Perinatal Support for Disabled Families education session. Brandie is a community-based doula as well as a research fellow in the Center for Disability Health and Wellness at the University of Michigan. And without further ado, I'm going to go ahead and turn it on over to Brandie. Thank you so much for being here and joining us today.
Awesome. Thank you, Helen. Hello, everyone, and good afternoon. Thank you for choosing to spend your Tuesday lunch with me. I appreciate your presence, and sharing in this virtual community space with you all. As I get started, if folks are comfortable just dropping your name and a little bit about your background, so maybe just your professional role in the chat, that would be awesome. All right. So there are three objectives for today's presentation. And I will warn you all that this is a topic I could talk about for days and days and days. And we only have 1 hour together. So I'm going to do my best to give you a primer. It is my goal that today's presentation will be simply an introduction, maybe a reminder for some, but just providing you with foundational information regarding disability and perinatal period. And we'll walk away with three objectives. So by the end of this session, you will be able to understand the significance of recognizing disability during pregnancy, childbirth, and early parenting to enhance care and outcomes, explore disparities in perinatal experiences and outcomes for parents with disabilities, and their impact on both individual and family well-being. And then lastly, discuss strategies for delivering inclusive, accessible, and supportive care to parents with disabilities throughout the perinatal period. I have a few discussion points throughout, and my presentation style is pretty informal. So if you have any questions or something comes up as I'm presenting, feel free to drop it in the chat or use the raise hand feature. I think our group is small enough that I'll be able to catch it and see it, and we can have discussion throughout too. So know that we got some built-in talking points at different times. All right. And I'm looking at the chat and see that we have a nice group today. Awesome. So I see some doulas, midwifery students, family prevention and education, program managers, community health workers, home visitors. Awesome. Okay, this is great. Thank you all for dropping that in the chat. So let's get started. So I'm going to start with a brief introduction. My name is Dr. Brandie Bentley. I am a maternal and child health researcher, And I have a background in social work. So I have a BSW, an MSW, and my PhD is also in social work. In addition to that, I am a community-based doula, and my research really focuses on promoting maternal health equity for disabled communities of color. So I'm very fascinated with the intersection of race and disability and how racism and ableism create very unique circumstances for disabled communities of color as they navigate pregnancy, parenting, early parenting, postpartum, and everything that those seasons bring. So I have both personal and family ties to disability that drive my passion for this work. I am of the belief that community health workers, including home visitors, doulas, um, community health workers, are all really uniquely positioned to be change makers, especially when it comes to advancing disability justice and perinatal care. So, as a part of my presentations, I also like to include a visual description, especially with presentations that are recorded. So, for those who may not be aware, visual descriptions can be very helpful for ensuring that everyone, especially blind or low vision participants, can fully engage with the presentation. So our voices may not paint a full image of who we are, and providing a visual description helps everyone feel more connected and understand how I'm showing up in this virtual space if they may not be able to see it for themselves. So I am a young Black American woman. I have vitiligo, so I have both brown and white skin pigment. I have shoulder length locks that are curled today. And today I'm wearing a striped white and black dress with black glasses and gold hoops. So I'm going to start by orienting us all on why this matters. Disability is often an afterthought in reproductive and maternal health conversations, and this oversight contributes to major disparities. So we know that disabled people face discrimination, inaccessible care environments, and assumptions about their parenting abilities. And home visitors, other community-based workers play a really critical role in advancing equity through advocacy, increasing access, and also offering holistic support to families. For today's presentation, I wanted to provide a broad overview of disability in its definition and different frameworks so that we're all on the same page. So disability is a very broad umbrella term. It covers physical, intellectual, developmental, sensory, mental health, chronic conditions, and more. Some disabilities are apparent, so thinking about things like mobility disabilities, limb differences, some neurological conditions, and others are non-apparent. So that could include mental health conditions, intellectual and developmental disabilities, learning disabilities, chronic pain, chronic illness, but both deserve equal care and attention. So it's important to recognize that disability may be lifelong. So some people may be born with their disabilities, others may acquire disabilities at different points in the life course. Some people may have disabilities that are very stable. Others may have disabilities that are episodic. And it impacts people in very different ways. So it's not the same and it looks different person to person. So here's a few models to help us understand how we think about, view, perceive, and understand disability. And the way that we think about disability and how we view it can deeply impact how we engage with different disability communities. So the medical model is maybe one that folks are most familiar with, especially in healthcare settings. It views disability as a problem within the individual and focuses on diagnosing, correcting, or managing impairments. So, for example, under this model, a person who uses a wheelchair is seen as having a physical limitation that needs to be fixed. So, whether that's through therapy, surgery, or the use of a wheelchair or other assistive devices, it views that condition as something that needs to be fixed. And this model has its uses, particularly when it comes to clinical care, but when applied exclusively, it could be quite limiting and harmful as it implies that the disabled person's body or mind is the problem rather than the system around them. So if we take it a shift that lens a little bit forward, we have the social model. And this is where disability is not seen as a flaw in the individual, but rather a mismatch between people and their environment. So the issue is not that someone uses a wheelchair, it's that the buildings, sidewalks, cars, and everything else in our society is not accessible. And this model helps shift the responsibility from fixing the person to fixing the system. So when we think about perinatal settings, this could look like asking, are clinics physically accessible? Are ASL interpreters available? Are policies flexible enough to meet different communication, sensory, or support needs? And then lastly, the one that folks may be a little less familiar with is the cultural model. And this model goes even deeper. So it encourages us to see disability not as a deficit or a barrier, but as a valuable form of human diversity. It's rooted in disability pride and disability justice, and it asks us to challenge ableist assumptions and see disabled lives as whole, rich, and worth celebrating, not just accommodating. And so if we apply this to a perinatal setting, it encourages us to see disabled people as experts in their own bodies. We value their lived experience, and we also advocate for their right to parent without judgment or surveillance, right? Which we know is very impactful, specifically for individuals with disabilities. So this aligns really nicely with the principles of reproductive justice. And it helps us truly understand how we're thinking about disability and how that's applied within different settings and how our personal belief and views on disability may differ with others depending on the setting and what that mismatch may result in. So I always tell people in these presentations, disability impacts everybody. So whether you realize it or not, disability impacts you. You're either an individual with a disability yourself, you have a loved one, friend, or family member who has a disability, or you will age into having a disability at some point. So right now, more than 1 in 4 adults report having some type of disability, and this represents more than 61 million people. And so that could include physical, sensory, intellectual, developmental, mental health, and so forth. And disability is the only marginalized group that any of us can enter at any given moment. Among women of reproductive age, about 10 to 12% identify as having a disability. And most importantly, disabled people are just as likely as non-disabled people to plan pregnancies and become parents. So the myth that disabled people don't want or shouldn't have children is deeply rooted in ableist history. And it's just that, a myth, because that's not what's happening, right? So if we don't see many disabled clients in our perinatal settings, it doesn't mean that they're not out there. It often means that one, our systems are not accessible, or two, they're not welcoming enough for people to engage or disclose. So people have disabilities and they're not telling you that they have a disability. At every stage of the perinatal journey, from early prenatal care to labor and delivery to postpartum recovery, disabled people encounter unique barriers and inequities. Like I said when I started, this presentation could easily be like 3, 4 hours, but we have 1 hour. So today I'm going to focus exclusively on 3 stages and just present a little bit of research from each of these stages to give you a solid foundation of what that looks like in prenatal care, labor and delivery, and postpartum morbidity in care. And so disparities often start early and continue throughout pregnancy for disabled people. When we look at delayed or missed care, researchers found that women with disabilities are significantly less likely to begin prenatal care in the first trimester. And so because of your diverse backgrounds, many of you likely know that early care is critical. This is a time that we're establishing rapport with our families, we're building trust, identifying any risk that may be present, and also offering key supports that will be sustained across the pregnancy. Um, but the issue goes beyond when care starts. It's also about how much care people receive and whether that care is adequate. So, multiple studies have shown that individuals with intellectual and developmental disabilities, also known as IDD, are especially at risk of receiving inadequate care. And they typically have fewer prenatal visits or their care is inconsistent and fragmented. But this does not look the same across all disability types. And so, like I said, when I started, I'm going to present a breadth of information and try to talk a little bit about different disability types because everything varies depending on what type of disability folks have. So, for example, when we look at barriers in the system, women with spinal cord injuries were found to receive more intensive prenatal care and they were less likely to deny their first appointment. And so some may hear that and say, yes, right, that's positive. This is good news. But it doesn't always translate to meaning that the care they receive is affirming. So, in fact, many of the same women within this study who reported positive relationships with their providers shared that those relationships were sometimes overshadowed by things like providers' negative assumptions. So that could look like surprise that the individual was pregnant at all, or a lack of provider knowledge about how disability could, in fact, impact pregnancy. Physical barriers play a major role too. So when you think about things like exam tables that don't adjust, no accessible weight scales, and a lack of accessible parking and transit options, those are a bunch of small barriers that add up and often make routine care that should be pretty straightforward and simple a lot more complicated. And so people end up having to rely more on emergency rooms. So, for example, women with IDD were nearly twice as likely to use the emergency department during pregnancy. And so you're already looking for care during pregnancy, but now you have to seek it in a high stress, reactive setting that's often due to gaps in coordinated care. So it creates an issue across the entire spectrum. So I have a quick discussion and reflection point for us here. And so folks can feel free to unmute or drop responses in the chat. But I have two questions. The first is, have families ever expressed discomfort or challenges after attending a prenatal visit? And then two, how have you supported families in navigating these challenges?
I have a personal experience. I am born deaf, so I have cochlear implants and I can hear and stuff like that. But in 2020, when I was pregnant, I had prenatal appointments. I had a hard time understanding providers because they had masks on, understandably. But I asked them for the birth if they'd be willing to wear a clear mask, like a mask I'll buy it for them and everything. And they said they wouldn't be able to because it was, again, hospital policy. So it was really frustrating because I didn't want communication barriers. And I'm fluent in ASL, so ASL interpreters would help me. So I was in kind of like that, people falling through the gap.
Yes, thank you for sharing that, Kristen. That is so important. And thinking about folks who are in limbo. So you have resources on one side, which disqualifies you from what providers are comfortable providing or accommodating. And we're going to talk about that towards the end too. So thank you for sharing your personal experience. Tanya said in the chat, for families in our clinic with cognitive delays, I ask patients if they would prefer I read the documents to them, and then I ask that they discuss it with me to make sure they understand treatments, referrals, et cetera, that is being recommended. Thank you, Tanya. Yeah, that's an important support. What about others? And I am perfectly okay with silence. I used to teach our social work classes, and I would tell my students all the time, silence means that people are typing or they're thinking. So I am okay with that. And Tanya also said, we also use video interpreters for our hearing impaired patients and non-English speaking patients. Mhm. That's a good one. And then Kristen says, I've also supported a blind pregnant person as a doula, and they had a difficult time getting resources that were accessible for them, including childbirth and breastfeeding classes. Hmm. Yes, thank you for elevating that, Kristen. Something that I'll touch on in this presentation too is that inaccessible environments and barriers to care extend beyond the healthcare setting, even in community-based settings and all of the other education and support that we receive throughout the perinatal period. Things are very inaccessible and people don't understand disability. And so it puts folks in a tight spot because your healthcare providers don't understand, and then there's limited resources and community for navigating the space. And so it's like, where do you go? How do you advocate for the things that you need to feel supported in your birthing experience? Yeah, awesome. Well, thank you all for sharing. We'll have some more of these throughout. So plenty of opportunity to share. So turning to labor and delivery, when we think about this, in an ideal world, labor and delivery is an experience that should center the birthing person's voice, safety, and comfort. But unfortunately, for some disabled people, that's not the reality. So, research consistently shows that women with disabilities often report dissatisfaction with their labor and delivery experiences. And some common reasons include too little involvement in birth planning, limited input into major decisions like the mode of delivery, the length of the hospital stay, or pain management options. And some birthing people even reported that they weren't asked how they wanted to give birth, and decisions were made for them, often based more on assumption than clinical need. And these disparities are often intersectional. And so when we look at race ethnicity, a 2019 study found that stillbirth rates were higher among non-Hispanic Black and Hispanic women with disabilities, which really shows how ableism and racism intersect to increase risk and also experiences of trauma during childbirth. And then lastly, some individuals with disabilities experience more difficult recoveries that include longer hospital stays and increased complications, especially after surgery or with spinal cord injuries. So studies show that surgery and anesthesia may be more complex for women with disabilities and that recovery can take longer. So sometimes they end up staying in the hospital longer than typical, and that adds not just to the recovery time, but also to stress, to care and support needs postpartum, and of course, to cost. Another discussion point. So I have three questions here. The first is, how do you support parents in preparing birth plans that reflect their preferences and access needs? The second is, how do you help ensure continuity of care and support once a family returns home from the hospital? And then the last is, what tools or community resources have been most helpful in addressing accessibility needs during postpartum recovery? You can choose anyone you like.
You all right? Watch that face.
So I've supported disabled parents before as a doula, and a lot of times they have specialists, well, some disabilities, they have specialists, and then they have like OBGYN or midwife. And sometimes there's a lot of not lack of coordination for their care. Like they have very conflicting advice for what are options for their birth. So I try to like tell them advocacy tools and teach them to learn how to coordinate and stuff like that. But I also understand that it can be very tiring to advocate for yourself for so long. So I try to teach partners you might have to advocate more in the birth space just because they're tired and they're also in the labor flow state and everything. Um, and if they have a spinal cord issue or something like that, I also just ask that they can have a meeting with their specialist and their anesthesiologist to see if it's possible for them to have an epidural, because I have had a couple that couldn't get one because the anesthesiologist didn't feel confident. So it was really painful and traumatic for them. So I try to encourage them to do that ahead of time if possible.
Yeah, absolutely. Thank you for that, Kristen. You brought up a lot of good points. And care coordination is huge. I've also supported a family um, who had a spinal cord injury, and that was the exact process, like meeting with all of the providers in advance, discussing options, talking about the anesthesiologist's, that's a long word, comfort with doing the epidural and how that process would go. And it looks very different. And I think exactly like you said, it can be incredibly demanding to advocate for yourself, especially during labor and delivery. So I agree wholeheartedly, thinking about the individual's full support team, assigning roles, having a doula present if possible, so that that responsibility doesn't fall solely on the individual, but it's able to be spread out and everyone is in the space and observing and taking it in and able to respond as needed. So I think that's an incredible strategy. Yeah. Any others? And at the end, I also have a piece talking about birth plans and how we could use that as a tool. But I could share it now too. I think similar to what Kristen said, going in prepared in advance. Birth plans are a very, very great tool because everything is in one space. You can share it with the healthcare team. And I think it's a great space to also know access needs and accommodations that are important. I was able to go to the hospital in advance with my family and look at the rooms to make sure it was fully accessible for their needs. We noted any of the things that we needed for accommodations on the birth plan. So anyone who was engaged in a in delivery was aware. And even with that, there were still challenges day of. And so having that birth plan handy and constantly having a point of reference to refer people back to is always super helpful because people forget or they don't read in advance. And so it takes a lot of that stress off of the family to not have to keep articulating it because they can say, here's our birth plan, here's our birth plan, it's right here. And I think sometimes that works well in those situations as well. All right, awesome. Well, thank you all. The final section we have is postpartum morbidity and care. And research has found that women with disabilities across many disability types are significantly more likely to experience antenatal and postpartum depression. So they're experiencing higher rates of depression during pregnancy and also after pregnancy. Similar to the prenatal period, those with IDD are particularly vulnerable during the postpartum period. And research has shown that they have much higher rates of hospital use, which is connected to gaps in outpatient support and challenges with communication, follow-up, and care planning. So they're experiencing more emergency visits prenatally and in the postpartum period. And then lastly, women with spinal cord injuries face distinct physical and emotional risk And so research has found that they have higher rates of postpartum depression and physical injury, which makes sense when we think about the demands of lifting, transferring, or caring for a newborn with limited mobility, especially if there are no accommodations in place. So I want to use this section to pull out a piece on intersectionality. When talking about disparities by disability, it's also important to note how disability, or ableism rather, interacts with other forms of oppression and creates qualitatively different experiences for disabled folks who have other marginalized identities. And so with that, I have a very shameless plug, and I'm excited to share that my research team and I have a study currently in press titled Perinatal Depression at the Intersection of Race, Ethnicity, and Disability. And so a lot of the research, if we look at trends among women of color, we see that they face disparities in perinatal mental health. And then we also know that women with disabilities experience elevated risk for poor outcomes and experiences. So there's overlap in racism, ableism, lack of healthcare access, social economic disadvantage, fragmented social support, and increased stress. And all of this is contributing factors to why people are experiencing higher rates of depression. But we don't have enough research that looks at what's happening at that critical intersection. Too fast, sorry. And so that is the study that I tried to fill the gap with, is looking at what is happening at that intersection. So using PRAMS data, which is Pregnancy Risk Assessment Monitoring System, collected in partnership between the Centers for Disease Control and Prevention and local healthcare departments, I looked at differences in antenatal and postpartum depression, specifically at that intersection of race, ethnicity, and disability. So this first table shows the results for the prevalence of antenatal depressive symptoms during depressive symptoms during pregnancy, stratified by race, ethnicity, and disability status. And so the key finding here is that women with disabilities across all racial and ethnic groups were more likely to report experiencing depression during pregnancy. So if we look at the table, the purple bars are individuals that do not have a disability, and the green bars are individuals with at least one disability. And so we can see that the prevalence drastically vary. So on the lower end, we have 10.2% or 14.6% for individuals who don't have disabilities. And then on the higher end, we're seeing, sorry, this is super sensitive today. We're seeing prevalences like 42.7%, 41%, 37.3%. So it's a much higher prevalence of depression during pregnancy. So it also looked at the prevalence of postpartum depression, and the table to the right shows those results. So although the rate is slightly lower than what we saw for antenatal depression, we still see significant disparities between individuals who have at least one disability and those who do not have any disabilities. And then most strikingly, in the postpartum period, women who are both disabled and American Indian or Alaska Native and disabled Black women are much more likely to experience postpartum depression than women who are only disabled or only from one of those racial ethnic minority groups. And so this really points to a compounding of race, ethnicity, and disability, and encourages us to shift our attention specifically to what's happening in postpartum period and what we can do to better support families across the entire perinatal period, specifically individuals with disabilities, because the prevalence is so high in both periods. Okay, so another discussion point. What signs or symptoms should home visitors be especially attuned to when working with disabled clients postpartum? And what has been your experience connecting families to mental health resources that are affirming of both disability and parenthood? And I can see the chat too, so feel free to drop any responses in the chat, or if you're comfortable, you can unmute yourself as well. Yeah, so Kristen said what their social support looks like and their belief in them as being capable parents. Those are important. That's a really, really big one. In this same study, I also just ran the demographics and compared the individuals with at least one disability to those who did not have a disability. And on average, individuals with disabilities in the sample were younger. They were more likely to receive WIC, less likely to be married, and most importantly, they experienced a significantly higher prevalence of stress during pregnancy. So if we say, for example, this is a proxy, don't quote me, but for example, if individuals with disabilities had 0 to 3 stressors most frequently, individuals with disabilities reported 6 or more stressors at a much higher rate than individuals without disabilities. So I think it's super important that we're thinking about the role of stress. And the stressors that PRAMS collects are pretty major life stressors. So things like divorce or domestic violence or having to leave your home. So thinking about all of those things happening at the same time during pregnancy, during postpartum, and how that could affect experiences of depression. And then if there is limited social support, so maybe you're not able to connect with other parents who have shared disabilities and learn from them, and you have the stigma and discrimination from providers who don't see you as capable parents. And then you layer that with the higher risk of being reported to CPS because of ableism and stigma in healthcare and other societal settings. And all of that compounds. It can be very challenging. And then Tanya says change of routine and client patient during home visits. Decrease in personal hygiene, untidy home, if this is a change, etc. Yeah. So I always tell people when I think about my own personal research and what we can do to improve outcomes for people, I think that home visitors, community health workers, and doulas are really perfectly positioned to think about mental health support because we're going into families' homes, right? We get a sense of what their normal looks like. We know what their support needs are. It's a lot easier for folks to say, hey, this is hard. I'm having a hard time today in the comfort of their home than it is in a medical office. So I always think about like what can we do within our own positions to improve outcomes or connect families with care because we have a different lens and our approach looks different. Our rapport looks different. The intimacy of our relationships look very different with families. And I think there's also a level of trust there due to the duration of the relationship, the intensity and frequency in which we're meeting with people and communicating with them. That's very different than what's happening in healthcare settings. And then Felice says, during my pregnancy and after, it was hard trying to find someone who was affirming. Absolutely. Absolutely. And I think that ties perfectly in. That's like the backbone of community health workers and home visitors and doulas is to provide that affirmation. So I think that that could be a really good strategy at filling the gap and thinking about how we are identifying needs for mental health support and also connecting families with care. Yeah. Thank you all. So in our final moment, I have a few wrap-up slides. And I want to start with some best practices for home visitors or any provider supporting disabled parents. And so as we've seen through today's very high-level presentation, disabled people face very real and very persistent barriers in perinatal care. But they also bring incredible strength and expertise and a deep knowledge of their own needs. And so I think at this point, it's common for folks to be asking, what can we do? How can we make things better? And here are a few North Stars that I use in my own work. And so the first is remembering that disability is not a monolith. So there is no one size fits all approach. You have to adjust person to person. You have to accommodate person to person. And it's not enough for us to say, well, we have these accessibility supports in place, because that doesn't mean that it's going to catch everyone in their specific needs. And so every person's experience is shaped not just by their own disability status, but also their race and their gender and their income and support systems and previous interactions with healthcare and all of these other layers. So it's really important that we approach each person as an individual and genuinely seek to understand how we can support them on a one-on-one basis. Something that has come up in the comments in today's discussion is also thinking about how we affirm individuals in their role of parenting. I think for everybody, parenting is a very hard experience, especially for new parents. Nobody knows what they're doing. We're all just trying to figure it out and survive day to day. And too often, healthcare providers and even individuals in community-based settings make assumptions about what someone can or can't do based on their disability. So I think it's important to always start from a place of respect, and assume confidence. Have belief in your family's capacity. And I think that's especially important when you think about individuals with disabilities, parenting ability being questioned from places of authority and also being surveilled, because they are at higher risk of CPS involvement and all of these things, because individuals in power are making assumptions about what they can or cannot do. My third piece is to ask thoughtful questions. None of us know anything. Like we don't know all of it. We will never have the full story. And so no matter how competent we think we are, or how inclusive, or how much we're leading with disability justice, I think that it's really important for us to ask open and respectful questions like, what does support look like for you right now? Or are there any accommodations that would make care feel more accessible, more empowering? I think that those very broad level questions can help us understand how we can show up for people in a more meaningful way. And it also supports the autonomy of the individual. It gives them the space to say, this is what I need, and this is what you can do to make my experience better. Something else that has come up today is thinking about planning collaboratively. So whether that's a birth plan or coordinating postpartum support, or also thinking about the coordination of care across providers, it's really important that we're involving our families at every step. And you include their doula, their partner, their family, their care team on their terms, because there are some times where people are like, I don't want my family involved. I don't want them anywhere near this process, right? And so having those very transparent conversations and understanding who is it that shows up the most for you in the way that matters and is meaningful to you, and involving those people accordingly. And then lastly, centering respect and autonomy. And so disabled people have a long history of being excluded from decisions about their bodies and lives. And our presence can be very powerful to counter that history. So I think it's important that we lead with trust and transparency and consent, and make sure that we're centering respect and autonomy. Because when we're in medical spaces, sometimes it's the doula, or sometimes it's the home visitor, or sometimes it's the community health worker that is challenging those very oppressive very oppressive systems, and the symptoms of those very oppressive symptoms. I mixed that up, but you all know what I'm saying. We have the power to really push against that and change the narrative. And so I encourage us all to use our power and our presence to do so. Because you have to call people out sometimes. And that is a reminder that I always have. Like, support can look like preparing the care teams to do better, or advocating behind the scenes. Like, it's not just the check-in points that we have regularly with our families, but making sure that we're connected with them and contacting them on a regular basis and checking in to make sure they feel good and seen, not just when crisis occurs. And then with that, I will also hold space. Is there anything else that folks do in their own work that they would like to elevate here as well? And I have the chat open too in case anyone's typing in the chat. All right. So feel free to drop it in the chat if it comes to you later. Cool. I also wanted to uplift the 10 principles of disability justice, because I think this is a really powerful framework that can strengthen our approach to supporting parents with disabilities. So we've talked about disparities, we've talked about barriers to access, and a few best practices, but disability justice really asks us to go further and move beyond inclusion and accommodation towards liberation and collective care. And so some of the questions that this framework pushes us to ask could be who is being left out of our systems of care, whose voices are not at the table, and how do we center the people most impacted in creating the solutions? And so something that really strikes me is that this work is new. It's in its infancy. Um, there's not much research on the experiences of disabled parents and further what support looks like. I think of existing resources and tools, a lot of stuff is centered towards what healthcare providers could do, but we're in a great era to think beyond that, to think about what's happening at the community systems level, to think about how we're engaging in collaboration and collective care in community, because that's where it happens. We're taking care of our neighbors, we're taking care of our family, we're taking care of our friends, and that is unfolding in a community setting. And so I think the principles of disability justice really helps us to challenge the ideas of who's creating solutions and also where those solutions are being implemented. So that's like a little piece to chew on as you think about it. And then I see Kristen put in the chat, disabled people sometimes experience paternalism in the birth space. So doulas can help by bringing the spotlight back to them instead of just talking to the non-disabled partner or parent about decision making in their care. Absolutely. That's a really good one. So before we close, I want to point you to a resource that I've developed to support you in taking this work further. I will share this after today's call, but it's just a PDF of the key studies and citations that were discussed in today's presentation. And there's also links to articles and toolkits and different research centers and advocacy centers that focus on disability, parenting, pregnancy, postpartum. And I think it's a good foundational list to get you started. And so addressing disparities requires more than one training, especially one hour training. And it's really important that we remain sustained and engaged in this work. And so if you have any questions or you want to reach out to talk more as I continue to learn, as I continue to do this work, both in research and practice, I'm always happy to collaborate around trainings or thinking about systems change or research opportunities, because it will take all of us to do what we need to do. I also pulled this specifically from the National Center for Disability and Pregnancy Research. These are two resources that I have listed on the list, the National Center for Disability and Pregnancy Research, as well as the National Research Center for Parents with Disabilities. I do think that a lot of the resources are more tailored to researchers and OBGYNs based off of my understanding of what's available. But if you're interested in getting more information on different topics, different disability experiences in pregnancy or parenting, they do have a wide range of research articles, some included on the list that I developed, and some beyond that as well that you can go through. And so I just pulled one example. There was an article that they have listed that said, wait, what? What's going on? Pregnancy experiences of deaf and hard of hearing mothers who do not sign. And in that article, they had listed a resource from the Hearing Loss Association of America. They have a communication access plan that I took a snippet of and put to the right side. And they were talking about how that could be incorporated into birth plans. And people could use that as an additional resource to advocate for accommodation needs. So it gives us somewhat of a template we could go off of, which I thought was helpful. So I do think there's a little bit of legwork that you'd have to do to go through the research, see what recommendations they have. But like I said, I do think from my perspective, a lot of it is tailored towards researchers, but they do have a lot of stuff that's also tailored towards parents. But it's a great opportunity to think about collaboration and how we could build resources for doulas and home visitors that are focused on what it looks like for us to increase inclusion and accessibility in home-based settings. So that's my other shameless plug, is if anybody wants to collaborate on that, I think it is a very great opportunity to kind of fill the gaps of what I'm noticing. Because I do presentations like this, and in most of the spaces I've been in, it's been the same thing. No one has concrete resources that we can use that feel applicable to home and community-based settings. So I think it's a really great opportunity for collaboration and growth in this area. I also want to elevate some additional trainings and workshops connected to this. The Michigan Association for Infant Mental Health is hosting me again on July 22nd. And so for individuals who are interested in learning more or going a bit deeper, we have an all-day training from 9 o'clock a.m. to 3 o'clock p.m. And we'll be talking about infant mental health practice with parents with disabilities, advancing equity from pregnancy through early childhood. And so if this is like part one of the introduction into disability perinatal period, this training is what I would identify as a part two. It'll be a recap of some of the same things that I talked about today, but we'll also have the opportunity to do some case studies and watch some video vignettes of parents with disabilities and talk about a lot more stuff in more depth because we'll be spending all day together. So I did note the price because it is $90 for non-Michigan AIM members, but $40 for members and students. So I'm not 100% sure how much the membership is, but that is an additional resource. And I believe there are 5 CEUs associated with this training, but I have it linked in the slide so you can check it out and see more if you're interested. And then I also have some of my friends from the Michigan Disability Rights Coalition on this call too. So thank you, Tamika and Felice, for joining us. I will actually hand it over to one of you to talk a little bit more about the lead-in cohort.
Okay, I guess I'll go. So my name is Tamika Citrus Bruce, and I am the lead-in director at Michigan Disability Rights Coalition. So Felice and I and another rest of the team members, we put together a cohort where we'll be working with 4 nonprofit organizations and community organizations on disability inclusion. And so within the cohort for a whole year, you'll learn everything about disability inclusion for both in programming, also when it comes to staffing and those type of things. You get technical assistance from myself and the team and some other experts. And, um, and so we really wanted to focus on maternal health organizations. All of the team, we are women of color with disabilities who are mothers. And so this issue is dear to our heart. So we would love for anyone on this call, who belongs to nonprofit organization or whatever the case may be, to apply. We have our on this flyer. We have the link to it. So I would love, please, if you could put it in the chat. I think you also will get it afterwards as well. So please fill out the interest form if you're interested, and it's free to attend. And in fact, we give 3,000 for stipends to each nonprofit organization, and we also give $1,000 towards technical assistance or whatever the organization needs. And so, we'd be glad to have you guys.
Awesome. Thank you, Tamika. And I saw in the chat someone was asking about recommendations for advocacy organizations that home visitors can contact. I think the Michigan Disability Rights Coalition would be a great organization to connect with if your organization has capacity to participate in the lead-in cohort. I think that would be an awesome starting place to learn more and get tailored resources and support for implementing sustainable practices. And correct me if I'm wrong, Tamika, but it's focused on not only better serving individuals with disabilities as clients, but also employment strategies for individuals with disabilities. So I think when we talk about systems change, and what organizations are doing to be truly inclusive from the inside out, this opportunity is a great resource for folks.
Yes, we also focus on staff as well, who have disabilities and how to better support them.
Awesome. Thank you, Tamika, and thank you, Felice. I see the links in the chat, and I'll also share a follow-up email with everything too, so you all will have that. All right. And so with that, I just want to extend a heartfelt thank you to the Region 9 Michigan Perinatal Quality Collaborative for inviting me to speak and creating space for really important conversations like this. I'd also like to thank the Center for Disability Health and Wellness for supporting my work. And then finally, thank you for each of you for spending your lunch hours with me and showing up and your thoughtful presence and engagement, and also the work that you do day in and day out to support birthing people and their families. It's been an incredible 1 hour together. I did want to note that I will be attending the MDHSS conference next week. So if anybody's like, yeah, let's connect, and you'll also be there, feel free to shoot me an email. It's listed in the slides. I will share a copy of these after today's session. And so I'm happy to connect with people in person next week or via Zoom, whatever works the best for you. So feel free to stay connected and take my email address and reach out if you have any questions or want to connect further. I will put it in the chat too.
Thank you so much. It has been such a pleasure getting to learn with you for this 1 hour. And you are so right. 1 hour, was certainly not enough. So thank you so much for everything that you shared and contributed. And I will see you next week, and I hope to see others there as well. Thank you all so much for attending today. We will make sure all of the good resources and follow-up materials from Brandie will be shared out with you all, and make sure that is all connected. So thank you, and enjoy the rest of your days. And we hope to see you next week or in other Region 9 events and times and gatherings. Have a great day, everyone.